everybody. So we thought that this would be a really great foundational training and a good way to kind of introduce the topics just for everybody. Since this is being recorded, we're able to play it back later as well, or maybe you have staff members that would like a better understanding of the system of care or the systems. This is going to be really high level. I'm not going to go into each different system and their individual programs. We're hoping that OHY and DCYF will be able to do a presentation as well for their own programs. So again, I'm Rachel Baxter. I come to you from Kittitas County on the lands of Wanapum, Colville, and Yakima. I am the Behavioral Health Stable Housing Policy Lead for Transitional Aged Youth. Some of the projects that I work on at HCA is identifying what evidence-based practices for discharge planning are there and what needs to be done, the research and support regarding services, resources, as well as working on an interagency team for the rapid response team, as well as 1860. I do work closely with DCYF, DSHS, Department of Commerce, so OHY, behavioral health providers, and housing providers. Some of the programs that I specifically am in is the prenatal to 25. So that includes WISE, CLIP, the Raw Reentry Group, inpatient residential programs, peer navigator programs, as well as some of the housing programs. And I will discuss some of those later on in the presentation as well. A little bit about me though, personally, I did receive my Master's of Science from Central Washington University in Law and Justice. I specialized in the intersectionality between race, class, and gender. I've been honored to work in many different fields regarding housing and homelessness. That's include the shelter program manager at Hope Source in Kittitas County. I was a social services provider. I worked as a child protective services investigator, as well as FRS and FBS. I also worked as a juvenile rehabilitation residential counselor and an engagement coordinator for the Mockingbird Society as well. So I'm very excited that there's so many people from the Mockingbird Society here. It's very cool. I became passionate about this work because I do have lived experience as an unaccompanied minor that was homeless on and off for about 3 to 3.5 years. I also was a teen mother, so I do have a 14-year-old son as well that I am on this adventure on. Again, very honored to be here, very excited to talk about these things. If you want to go to the next slide, Erin. So what does a system of care mean? I also included all of my links on the PowerPoints. You should be able to receive those. Hopefully the links work. If they don't, please let me know. I think Erin's going to try to pop some also in the chat as well. So a system of care is any public entity that offers any sort of services to youth and families, such as healthcare providers, behavioral health care, juvenile justice, DSHS, and we'll actually go through each one of these systems, again, at a very high level. So that those systems are those public systems, and all of those systems work together and separately. And there's a lot of overlap. So one of the overlaps, for instance, would be CLIP as a behavioral health treatment facility. However, a lot of those individuals that go into a CLIP program also have DCYF, child welfare, or JRA experience as well. So there is overlap between the systems. If you go to the next slide. So again, publicly funded system of care, I took it directly from the RCW, so each of you would have that information as well. The goal of legislation was by January 1st, 2021, any unaccompanied youth discharged from a publicly funded system of care in our state will be discharged into safe and stable housing. That publicly funded system of care means, again, child welfare, behavioral health system, juvenile justice, program administered by Office of Homeless Youth Prevention and Protection Programs. Next slide. So those publicly funded systems of care that we're referring to, that behavioral health system is with the Healthcare Authority. So that's acute care facilities, substance use, CLIP, state hospitals, long-term civil commitment, child welfare systems and juvenile rehabilitation. So foster care, extended foster care, CPS, CFWS. Juvenile justice systems, that does not include just JRA, that also includes county detention facilities as well, and Department of Corrections facilities. And then OHY programs, which is something we're still trying to conceptualize as well. You can go to the next one, Erin. I think I break it down. Yeah. So yeah, again, we'll go back: Healthcare Authority, acute care facilities, hospitals, evaluation, treatment facilities, substance use, really those inpatient facilities where a lot of youth are then being exited, like Jim had said, into homelessness. If you want to go to the next slide, I think I already overviewed some of these. Child welfare system also includes foster care, extended foster care as well. I did add the DCYF website to the youth services programs as well. Each one of those programs also has a different age range to it, so you will have to look specifically into those age ranges. And then juvenile rehabilitation counseling, the 2 institutional facilities as well as the 9 community facilities. Go to the next slide. The juvenile justice, this is actually something that I am currently working on right now. I have identified for HCA that this is a gap, not just for MCOs, but also just for communication as far as what is happening within discharge, what is their actual process. So if anybody has any contacts or connections with any of the local JJ facilities, please let me know. I would love to speak with them on what their processes are. And then Department of Correction facilities, that also has a link to it for all of the Washington State juvenile detention facilities. I'm gonna go to the next slide. So Office of Homeless Youth, this is what I was discussing about trying to conceptualize what is considered an exit from those programs. Yes, the crisis residential centers, which is a temporary residence for assessment, referrals, and permanency planning. They usually range from 12 to 17, as well as having conflict in their home, having ran away from home, or whose health and safety is currently at risk. There's also the Hope Centers, which is another temporary residence for assessment, referrals, and permanency planning. That's for street youth under the age of 18. And then OHY also has various rental assistance and stability programs as well. I also have added a link to their provider list as well as the provider map. So you're able to see what OHY programs are within your own community. They also have the street outreach services and the young adult shelters. So that would be one system that they're exiting that we would need to be notified of. However, I'm sure as many of you know, those programs, those individuals are still considered homeless while they're in those programs. So again, just something we're trying to work out currently. And then next slide, the DSHS DDA, who has residential stabilization services, short-term residential habilitation support designs to prevent unnecessary hospitalizations or institutions. We also, let's see, where is it? The Diversion Beds Residential Habilitation Center, which is 16 to 21. I'm currently working on getting more detailed housing information regarding those programs currently, so I should be able to share that at the next meeting as well. And then a common question that has been brought up in various other meetings that we've had, including with Jesse and Nicole, is Eastern and Western State and Harborview considered publicly funded? And the answer is yes to those. So those are also considered an exit as well. Sorry about my dogs barking in the background. So what is currently being done? So with these different systems and with legislation, all of these are required to have different responses as well as different obligations. So that stemmed initially from Second Substitute 6560 or Bill 6560, and then House Bill, from that, it was House Bill 1860, House Bill 1905, and then the 30-day MCO notification benefit for JRA. If you want to go to the next slide. So Senate Bill 6560 identified that no youth is discharged from a public system of care into homelessness. Specifically, 6560 aims to prevent young people from experiencing homelessness after being discharged from a behavioral health setting. I've given the RCWs later in the resources as well, if you would like to look those up. This was after, as Jim stated, the 2018 report released by Away Home Washington, and it found that 2 out of 3 13 to 24-year-olds experienced homelessness after they had been discharged from a public system of care from inpatient behavioral treatment. OHY presented in 2017 data from RDA illustrating that within 12 months of exiting inpatient behavioral health treatment, 1 in 5 young people ages 13 to 24 would be homeless. 82 to 84% of these young people are between 18 and 24. So on this slide, you will also find the Away Home Washington report, the Safe and Supportive Transition to Stable Housing report that HCA also released, as well as the fact sheet, which discusses all of that information as well. Next slide. So House Bill 1860 is the MCO notification. Providers must give at least 24-hour notice of intended discharge to an MCO, which is a managed care organization, to contact the individual being discharged to coordinate additional services. Those services include care coordination, which also includes housing coordination and resources as well. This also gives an extra layer of accountability to ensure that a discharge plan has been completed and that it's realistic and it's also client-centered. Within there also is on the last slide, there's the Gov requirement within there as well. As Nicole had discussed, there's also House Bill 1905, which is the Rapid Response Team. The Rapid Response Team is an interagency team that will receive referrals regarding transitional aged youth that have been exited from a system of care and have not been able to identify a housing resource at any lower level of care. So the goal is for the individual to receive those resources and the coordination prior to being referred to the Rapid Response Team. We're wanting to utilize that as a last resource. So for instance, if it was an unaccompanied minor being released from a behavioral health setting, then the bridge would be great for that. And then if the bridge is not able to assist with that, we're kind of utilizing the bridge as well as a liaison to refer to the Rapid Response Team. However, any provider, the individual themselves are also able to refer. That is spearheaded by DCYF as well. DCYF will receive or will have a coordinator that will receive those referrals, be able to discuss with the referent and the individual what the needs are and what they've tried in the past, and if they need any additional ideas that can happen immediately, or if they need a case conference by the Rapid Response Team. The Rapid Response Team will also work in tandem with other providers. It's not to replace any of the providers that are working with that individual specifically. Next slide. Oh, sorry, it got cut off there. So specific to JRA is the 30-day MCO notification and benefit reactivation. So this is 30 days prior to somebody within a JRA facility being discharged or released, having that MCO be notified if there is a housing insecurity or instability, and having their Medicaid benefits reactivated while they're in the facility for 30 days, which is not something that had happened previously. So being able to have the MCO contact the individual, have additional accountability for discharge planning, and ensuring that it's individual centered and focused, as well as if there's any additional barriers, the MCOs will be able to assist with that care coordination, or even identifying if there's a financial need, such as maybe utilizing the YDIP funding to kind of try to mitigate that barrier for the individual. It also is applicable for parole case managers, the JR Regional Mental Health Coordinator, Community Assisted Release, and then the JR WISE Coordinator. So everyone on the team will be communicating with one another. Next slide. So this is just a resource page that has the information that I discussed, as well as, I know that Gina is here. I wanted to add the Youth Regional Behavioral Health Navigations team, which is another great resource within specific, or within, I think, all the communities. And Gina, correct me if I'm wrong, within all the communities to assist creating a behavioral health or finding behavioral health resources for an individual as a team. Is that right, Gina? Okay, making sure. Really great resource if you would like to utilize it. Next slide. So one of the purposes of doing this training as well was to discuss that managed care organizations do offer care coordination. Again, that it does involve housing resources as well. There is a link to our website, as well as the 5 managed care organizations that we're referring to. These are usually, you know, some of our clients might refer to as state pay or provider one, or some variation of that. And that's what they would be referring to. Is Nicole, are you still here?
I'm still here.
So if an individual wanted to find out what managed care organization they have, how would they go about doing that?
If they should have a card, like a provider card, that would have a phone number on it, like a provider one card.
Perfect.
Yeah.
Okay, so then that's how you would be able to find out. What if they don't have a card, Nicole?
Let me get a contact. If they don't have a card, let me email real quick and get a contact for you.
Perfect, thank you, I appreciate it.
Yeah.
So I do believe within the systems thus far, this has been a gap for individuals that are unaccompanied minors. I know personally, I was not aware that there was case management or care coordination by the MCOs. So it's just an additional resource. They can help with concrete goods, or some concrete goods as well, such as a phone or things like that. So if you are in a JRA facility and you do get that 30-day notification, there's a possibility that you could get a phone or other resources prior to being discharged, which is great for individuals, especially for MCOs to continue that care coordination and communication with that individual. Next slide. So HCA also does have housing programs such as GOSH, HARPS, Foundational and Community Support Services. You can find all of that information at the Discharge Planners Toolkit, which is also linked here. That way you're able to go through a scenario and actually find out what that individual qualifies for, specifically if they do have a disability or they are needing inpatient treatment or any sort of behavioral health care. There's also the Washington State Housing Program Matrix that shows all of HCA's housing programs. And then I also included FCS program quick reference. In order to get involved with FCS, You can call that phone number. You don't actually have to go through coordinated entry, which is really cool too. And then next slide is just acronyms, since this is foundational, so everybody has them. And if you have any other questions, I would be more than happy to answer them. If I don't have the answer, I will go find it for you. And so make sure you put your contact information in the chat and I'll get back to you.
Yeah, anyone have any questions of Rachel? Anything you want to add that you know that to embellish anything that she said?
Jim, this is Gina. I wanted to see if I could add to something you put in the chat
Please.
about the idea of having a panel of MCO staff to discuss what the managed care orgs can do. I can't speak to everything they do broadly, but would it be helpful if I was able to copy and paste all of their contact informations into the chat so that you'd have a local connection for behavioral health case management?
Yes, that would be great.
Great, I'll drop it right now. Thank you.
Hoping Aaron might capture the chat. Sarah, please.
Yeah, thank you so much.
I'm sorry. Thank you, Rachel, very, very much for that training. Go ahead, Sarah.
Yeah, Rachel, thank you. And as I was listening to you sitting here, Jim and Rachel, I think it would be really important to do this training, or whether it's Rachel doing it or the bridge, for Amanda Lewis's discharge planning group. There's a group of residential inpatient. I'm sure, Rachel, you're nodding, but we all meet. And I think that is a really good opportunity to get this information out as a fact sheet for all the residential inpatient providers, so that we can really start to implement that into the agencies that are discharging people. So that was my thought. Thank you so much.
Yeah, no, that's awesome. Yeah, other comments or thoughts? We really want this kind of generative thinking and we really want you to help connect us with folks who might be of value. So I would even invite Amanda to come provide a training or a spotlight on what that work is about. Okay, thank you again. So we are a little behind, but I still want to take 10 minutes to do our generative question. And the question that we wanted to ask was really about, what do we need to be mindful of when we think of this customized return to community planning, this case conferencing? The other thing that I would put on the table is, if you just want to add into that, what trainings would be of value to you as we try and bring this cross-system work together? So again, last time I asked and nobody wanted to do the breakout. They wanted to have the conversation with the full group. And then we got feedback in the survey that some people wanted the breakout. So Aaron, if you're able to do that, why don't you break us up into a couple of groups? If you can, make sure there's a steering committee in each group, and it's going to be abbreviated because we want to stay on track. We have another really neat, quick presentation for you. So maybe 5 minutes at the most, 2 to 5 minutes, and discuss. And I know people have to start taking off, but yeah, just what do we need to be mindful of as it relates to customized planning? So an obvious one is confidentiality and releases of information, but even beyond that, those of you who do planning, what are best practices around that? And then if you get time, talk about what kind of trainings that either you could provide or that you would like to receive as it relates to improving this return to community practice. Please identify somebody that's comfortable reporting out. It's not a big formal thing. So anybody who's comfortable, and then the other members of the group can chime in.
You should now be invited to rooms and you can go join them.
Thank you.
Mm-hmm.
Well, we're in the spot right now where we really are running out of time. I often say an hour and a half, that's way too much time. And then here we are. And some of that is our introductions and that. But what I want to do is go to Rosemary, and then if we have time, we'll come back to get some of your input. Otherwise, maybe we're going to do a poll at the end. Maybe you can put some stuff there. I know we got a lot of rich content. I don't know what to do, but I know Rosemary got ready for this agency spotlight, and I want to respect that as well. So Rosemary, do you want to take a few minutes to tell us about the program you work at?
For sure. Hi, everybody. My name is Rosemary. I have around 6 years of experience with inpatient mental health care that we have in Washington State. The first 4.5 years being as an on and off patient, and the last 1.5 years as a technician. I'm currently working at, I can kind of hear myself over someone's mic. Anyway,
I did too, but it looks like it might be done. Please proceed.
Great. I currently work at Pearl Youth Residence, a children's long-term inpatient program that supplies the kids in our care with medication management, individual and recreational therapy, case management, and 30-minute checks every day to ensure residents are safe. My role as a technician is to, for 40 hours a week, complete the half-hour checks and ensure that residents are safe by de-escalating verbally or intervening physically if that's what's necessary. Our residents are from ages 11 to 17, and we are able to care for up to 27 children if we're fully staffed, but I believe right now our capacity is 22. The kids we work with are at a level of need to the point where their treatment can last anywhere from 3 months to over a year. The strengths that I would say that we have there is that we're full of staff that genuinely really care about these kids and want the best for them. The weaknesses that I would say we have are weaknesses that I can see across mental health inpatient places in general. The turnover is insanely high. The burnout is very much a problem for the floor staff and really staff in general. We can struggle sometimes with kids with certain behaviors that tend to upset people more. I think that would be it for me. I'm mostly just here to learn more from y'all because while I do have a lot of passion for the work that we're doing, I don't have a ton of experience in the management of people's plans and cases. I've just been a floor worker that gets screamed at for 40 hours a week.
Well, thank you, Rosemary, for presenting on Pearl. And Rosemary is also part of a steering committee member. So we do have a minute or two, and then Aaron's going to put up our poll, and I hope you fill it out. We're required to report this out to the Healthcare Authority. But yeah, what I know my little breakout room, and I don't see, looks like Jason may have left. But I thought we discovered some real philosophical differences. So anyone want to report out on what you heard in your breakout room related to discharge planning, return to community, or anything like that?
This is Rachel. I just want to acknowledge that my group brought a lot of really great ideas and a lot of, foundational trainings that we really do need to have regarding, MCOs, insurance, behavioral health, and then housing providers and how each of those processes really work in day to day. So really great ideas.
Great. Hopefully you captured and can share them. Others? V, what did you think about the conversation you were part of and overheard?
I have a lot of thoughts. They're all on the provider side of perspective, so I wanted to add stuff as a youth and young adult that's been through the system, as well as like hearing a lot of other youth and young adult stories. Let's see. There were comments on medication management. Hold up 1 second. And like the consistency of people taking it. I think aside from that difficulty, you know, like it's more about like, I don't think we ask enough about like how the medication's actually affecting the person. And what I see a lot of times when the case manager or someone tries to diagnose them, it's always just like depression or something. And then they're fed antidepressants, in which a lot of people, like if let's say if they're failed to diagnose that they have bipolar or something like that, they're most likely are going to need a mood stabilizer to balance that out, or else just having antidepressants would potentially, or most of the time, spike up their manic episodes. So it's just like managing that shift in personality and all of that. It makes it so that it's more difficult to manage your medication in general. Another thing is, what was it? There's a lot of talks about lack of motivation when the youth and young adult are there. It makes more sense than you think, right? If they were just happy and able to function in there, they wouldn't be in there. So when someone mentioned that, I just thought it was very victim blaming. You know what I'm saying? It's just kind of like, oh, like, it's your fault that you're not. I know you don't mean it in that way, but that's often what youth and young adults hear. And also the term sick, calling them sick, I don't think that's very appropriate, because like, let's say you were in that center and you're trying to express all the harm that you've been through, and then you're categorized as sick. I don't think that's very appropriate. Another thing is when they're trying to exit, a lot of times people don't take into consideration the emotional damage when they're in there. Like these facilities, it's just like they're often chastised for feeling angry or spiteful, when it makes sense, right? What if you're locked in a facility, involuntary or voluntary, like when there's just no consideration for independence, like you're following like a little system. So once you're outside to like the real world, like there's not much time to transition. And oftentimes, like once they're out there, they go back to old habits, right? Because that's all they learn. They've just been conditioned in there and they're going back out. So it's just that like lack of connection within it. There's not really, how do I say this? I wrote a lot more than this. And then when there's often times when you're there and it's just like you're working towards a goal to get better or to be successful, which is important, but also like there's no opportunities. Maybe it's better now, but like there was no opportunity for you to regulate your emotion, or like let's do activities outside of survival tactics or all of that, right? So you're just focused on this one thing, but like you have to realize that they're human too. And part of like that safe and stable network is that you're able to find enjoyment in something in life as well. So that was the thing that was lacking. After you're released, like you have no money either. You know what I'm saying? So it's like it's hard to maintain your medication, like your transportation to all these facilities and all that if you have no money, right? And then also like you're not prepared to be independent at all. Usually with the staff too, the staff I've encountered, I had a lot of negative experience, and there was no accountability on their part. It's not modeled when they do make a mistake or they're being harmful to a young adult or a youth, that you need to admit to your mistake and don't do that again. So because it's not modeled there, it's like you're not, if you're someone in that facility, you're going to be angry, and you don't know, like I said, it's not modeled, so they're probably not going, it's not a behavior that they're learning either.
V, I'm going to interrupt. That is really powerful. I think the group's going to look forward and benefit when we finally have a panel of young people with lived experience talking about their experience. So I'm interrupting not because what
No,
you're
yeah, I
saying is
have a
very,
lot,
very
so,
important, but just
yeah.
mostly because of time. Mayana, did you want to make the point verbally that you put in the chat? I thought it was powerful.
Yeah, sure. Can you all hear me okay? I don't know how my
Yeah,
internet is.
great.
Okay, perfect. Okay. Yeah, so the main thing I wanted to bring up, and this was like I said, we had other points discussed. So if other people want to talk about those, they definitely can. But one of the big things that my group discussed was just that so like I talked about my personal experience as a youth in a system of care for mental health care. And like my experience was actually like not a very good one. So basically I was just made to like essentially pinky promise that I was going to be safe. But then they didn't like, and we had coping skills and stuff in my safety plan, which is all great and helpful to an extent. But like when you're returning to the same exact situation that like made you need that support in the first place, that's like you need more than just coping skills. Like you need other supports, other people there with you. And so in my personal experience with it, they made the safety plan, but they didn't include either personal supports like people in my life that I could go to, or they didn't include like clinical or professional supports either, or even like any resources for like my homelessness situation, because I was technically a runaway and an unaccompanied minor at that point. So they just kind of skimmed over all of that. It just felt like I was basically just being pushed out, and they didn't really like actually care about how I was doing after I left, you know? And yeah, so that's essentially what I said in the chat. But basically just needing more focus on both personal and clinical supports in your area that are actually able to help you in continuing your like healing and your stability, essentially.
Thank you. Thank you very much. Well, Aaron, you want to do the poll? We're going to close. I wish we had more time. We're trying to get enough foundational content so that we can get to more of these kinds of conversations, which is, I think, is what's really going to be interesting. While Aaron's setting that up, I would like to say, for those of you who are inpatient providers, if you have any interest at all, I would really love to meet with you in between meetings. I feel like that's the entity that I know least amount and is hardest to sort of organize, quite frankly. And I think in the group I was in, there was some obvious philosophical differences that I think it would be good to figure out how we can make sure we have those important conversations in a way that feels respectful to inpatient providers, the young people who are accepting those services, and then the housing providers. So anyway, I'll put my email in the chat. And yeah, we're trying to get outpatient providers too. We need help kind of getting the full continuum at this table. And so I'm willing to meet with anyone you want to set up or can help with around the state in between meetings. And we have the poll coming up, I'm sure.
Yeah, so I will need Jen or Jim to launch that. And I can give you instructions.
I will take instructions. Jen can probably do it faster, so either way.
Please go to polls.
I think I'm on it.
Okay.
3/28/23 launch.
Yes. And this is for folks who are eligible to receive stipends. To verify your attendance for this meeting, please. Take a moment to respond and verify your eligibility for our reporting requirements.
And I know that we're at time, and I know many of you need to bounce. Well, we got 3 more minutes. Give us that much.